Good evening, everyone. We're getting ready to start. Welcome. Give people a minute to come in. So I'm Jennifer Talley. I'm an assistant professor here at the New School. I'm also the assistant director of the concentration in mental health and substance abuse counseling. I'm also the assistant director at the Center for Optimal Living, which is a clinical services program and training institute here in New York City. And our director is Andrew Tatarski, who's one of our speakers here tonight. So it's a real honor to be here and to be able to introduce this amazing panel of speakers that we have that you're about to hear. We've been planning this event for several months now, and it really arose out of conversations that Andrew and I were having this summer about what we were hearing in terms of the opioid crisis across the country, but also specifically here in New York. And so we wanted to host, an event, a gathering, to really listen to what's being done. What are some new solutions that we can think about together as a community, with input from users, with input from people in the community that are working in public health. How can we all come together to really tackle this as a community and to really give people options? And I think harm reduction is really well suited as an approach for addressing this issue of opioid misuse, because people aren't maybe ready to embrace abstinence, but they might be ready to work on reducing risk, and they need options. They need strategies, options, and one size does not fit all when we're thinking about treating this really complex condition. So I'm really, really thrilled to be here, and I'm really happy to see you all. And so I'm going to introduce T. Thaddeus Brown now. He's going to be our moderator for this evening, and he's currently employed in a variety of not-for-profit and for-profit professional workforce development, doing direct service and indirect service, and he also works as an independent consultant. So we're very lucky to have him helping us tonight as a moderator, and then he and I will also do the Q&A part after. So just a quick thank you to this amazing panel and all the speakers that you're going to see tonight. It's a pretty amazing lineup. So we have folks here from the Department of Health and Mental Hygiene. We have people from Harm Reduction Coalition, the Center for Optimal Living. We have people here from the New School and Families for Sensible Drug Policy. And we'll go over to Chief Thaddeus.
Thank you. I want to thank the organizers for this event, for inviting me to be a part of delivering this very important message and engaging with each other in this critical conversation, one that needs to be championed and advanced to the greatest degree possible, because at the end of the day, it's about saving lives, one life at a time, and as many of them as we can save as possible. That is the end game. It is a joy anytime that I have the opportunity to talk about, working with individuals, communities, society in general, in terms of helping people to improve the quality of their life. I'm not going to run on and on and on. I have so many things that I'd like to say, but what I will say is this here. By the end of this program, if statistics are correct, we will have lost some lives. The crisis around opiate overdose and the lives that it's claiming through death and severe abstinence is incredible. One thing I will say is that although this is a crisis point in history, the issues and challenges as it pertains to opioids, use, and the detrimental effect that they have on individuals in society is not new. For those of us who have been in the field for a while, we know that this is something that we've been combating for decades. And folks before us were combating it as well before we arrived on the scene. This program, again, means a lot to me. I'm going to share something with you which I think really touches home on why we're here this evening, as one size does not fit all in terms of how a person may move through a progress of improving the quality of their life. And they're quite naturally part of that in saving their own lives. I believe all recovery and all improvement of the quality of life as it pertains to any type of harmful alcohol and or drug use begins with the process of harm reduction. Here's a little something here. Do no harm. As a culture, we have heaped pleas, profanity, prayers, punishment, and all manner of professional manipulations on the alcoholic and addict, often with little result. With our 2 centuries of accumulated knowledge and the best available treatments, there still exists no cure for addiction, and only a minority of addicted clients achieve sustained recovery following our intervention in their lives. Given this perspective, addiction professionals who claim universal superiority for their treatment disqualify themselves as scientists and healers by the very grandiosity of that claim. The meager results of our best efforts, along with our history of doing harm in the name of good, calls for us to approach each client, family, and community with the utmost respect, humility, and devotion to the ultimate principle of ethical practice, which is first, do no harm. Above all, recognize that what addiction professionals have done for more than a century and a half is to create a setting and an opening in which the addicted can transform their identity and redefine every relationship in their lives, including their relationship with alcohol and other drugs. What we professionally are responsible for is creating a milieu of opportunity, choice, and hope. What happens with that opportunity is up to the addict and his or her higher power. We can own neither the addiction nor the recovery, only the clarity of the presented choice, the best clinical technology we can muster, and our faith in the potential for human rebirth. That was by Marty N., revised somewhat, out of Slaying the Dragon by William L. White, The History of Addiction Treatment and Recovery in America. At this time, I would like to introduce our first speaker, Denise Payon. Denise is the Senior Director of Research and Surveillance in the Bureau of Alcohol and Drug Use Prevention, Care, and Treatment at the New York City Department of Health and Mental Hygiene, and a distinguished fellow scholar at the CUNY School of Public Health. She received her master's and doctoral degrees from Columbia University. Dr. Payon has more than 25 years of service and leadership in the areas of public health, harm reduction, and substance use research. Dr. Payon, I'd like to invite you to the podium.
So I'm going to sort of set the landscape of what we know about the opioid epidemic in New York City by presenting some mortality data. And my colleague, Gail Goldstein, is going to present the responses. So while we have really good data at the Health Department in New York City, we actually really use that data for programming. So I'm sure that many of you are aware of the burden of overdose death in New York City. So more New Yorkers now die of a drug overdose than they do from homicides, suicides, and motor vehicle crashes combined. Drug overdose is the leading cause of premature death among New York City residents, and it's the top cause of death of residents aged 25 to 34. More than 80% of overdose deaths involve an opioid, and that's really important because opioid overdose deaths are preventable. I'm going to show you now data on actual overdose mortality, and we have data that goes back to 2000. So the data in the blue lines represent the number of deaths, and the pink line are rates, and that's a rate of 100,000 New Yorkers. So you can see that in 2000 there were 638 overdose deaths, and I'm just going to click forward where in 2016, there were 1,374 overdose deaths in New York City, and that's the highest number on record. And what that means is that every 7 hours, someone dies of a drug overdose in New York City. We just released about 2 weeks ago, very recently, we started to release very timely data. So we've now released the first 2 quarters of 2017, which is quite unusual. But because of this epidemic, we're really trying to get data out there so it can be used. Unfortunately, what we see in this provisional data is that things are not leveling off. We anticipate that we're going to see numbers as high as 2016 and probably a little bit higher. So what do we know about the people that die of overdose deaths in New York City? There are more males than females. In 2016, there were over 1,000 males that died of an overdose death. The numbers are highest among white New Yorkers and among those aged 35 to 54. However, there are disparities in overdose rates by race and ethnicity, and they varied over time. I just want to point that out. So in public health, we always talk about both numbers and rate. There's a difference between burden and risk. So if you look at this slide here, what you see is in the early years, the rate was highest among Black New Yorkers, and it kind of went back and forth between Black New Yorkers and white New Yorkers, and it was lowest among Latinos. But starting around 2008, 2009, we saw a gap growing, and the rate became higher amongst white New Yorkers, and that was primarily driven by the opioid analgesic crises, and also a decrease in cocaine-involved overdose deaths, which was most common among Black New Yorkers. But what we see now in 2016 is the gap is closing again, because we're seeing increases across the board. So this is a map of the city that I'm sure you're all familiar with. And really what we're highlighting here are the neighborhoods with the highest rates. So the neighborhoods that are outlined in yellow, it's the 5 neighborhoods with the highest rates. And there are the 3 neighborhoods in the South Bronx, East Harlem, and the South Shore of Staten Island. Again, talking about the difference between numbers and rates, you've heard a lot about Staten Island. But so if you look on the left-hand side, what we're showing here are the rates. So it is true Staten Island has the highest rate compared to the other boroughs, 31.8. However, you look at the pink bars, those are the number of deaths. While Staten Island had 116 deaths, and every death is really important, the burden in the Bronx is really high, 308 overdose deaths in the Bronx. And just to go a little bit more granular, on the left-hand side is Staten Island. So if you look at Staten Island by neighborhood, you really look at the South Shore, you see that the rate there is really high, 36.7, and that's like high like West Virginia, which has the highest rate in the country. While in the South Bronx, you also see those 3 neighborhoods there with extremely high rates and 155 overdose deaths. So what do we know about the drugs that are involved in overdose deaths? 82%, as I mentioned, involve opioids. Nearly 3/4 involve heroin or fentanyl, and about half involve cocaine. So fentanyl is really what's driving this dramatic increase in overdose deaths. And just so that everyone's clear, that fentanyl is a potent synthetic opioid analgesic, very short-acting, 50 to 100 times more potent than morphine. And in this context, we're talking about illicitly manufactured fentanyl. We're not talking about pills, patches, lollipops. It's illicit fentanyl produced in laboratories. We know from data that we received from NYPD lab that fentanyl is appearing in heroin, cocaine, and pills. And because it cannot be detected by sight, taste, and smell, it really has been a challenge. And despite all the work we're doing, we're still seeing the numbers and the rates going up. So this actually just shows you what we're seeing with fentanyl. It's really dramatic. And I'll just summarize it for you. Prior to 2015, less than 3% of overdose deaths in New York involved fentanyl. Now, more than 50% of overdose deaths in New York involve fentanyl. But a little bit about the demographics. This data here suggests that there is not a separate fentanyl market in New York. The demographic profile of decedents with fentanyl mirrors the profile of those with heroin without fentanyl. And I just want to call your attention to cocaine, and the reason is that we had seen a downward trajectory of cocaine for several years. We're now seeing an increase in cocaine-involved overdose deaths, but more importantly, what we're seeing is an increase in cocaine-involved fentanyl deaths without heroin, but with fentanyl. And that's very worrisome because it suggests the person was probably looking to use cocaine, the product was cut with heroin, with fentanyl, they are likely opioid naive and therefore at higher risk of overdose. In response to that, one of the pilot projects that we're starting, and we're going to launch it in the next couple of weeks, because of the association of alcohol and cocaine and recreational users, and we need to message around that with people that may not identify as a problematic drug user. We're going to go to bars on the Lower East Side to ask for their help, to put up a poster to alert people that the cocaine that they're using and maybe using in the bar, although we don't have any confirmation of that, maybe cut with fentanyl. They should be aware of that and follow our harm reduction messages that advise people, not to use alone, not to mix substances, and to have naloxone on hand. And we'll offer to train any bar that's interested in naloxone training. And finally, while Gail's going to talk about all the city responses, I just wanted to point out, because we have all this timely data and are very committed to using it, we have developed a new initiative which we're calling a Rapid Assessment Response, RAR. So we can do targeted interventions at community levels. And it's really modeled on an infectious disease outbreak investigation. So we have data, we can identify it in geographically bounded areas. And we can go in and do a very rapid assessment of what the need is and then respond quickly. We've done 4 of these so far in the North Bronx, South Bronx, Lower East Side, at East Harlem, and we're about to launch one in 3 neighborhoods in Brooklyn. And I think I'm just going to leave it there. Thank you.
Thank you, Denise. Now I would like to invite to the podium our next speaker, Gail Goldstein. Gail is with the New York City Department of Health and Mental Hygiene, and her bio is about this long. So I'm going to go through it as best as I can. Gail is the Senior Director of Planning and Programs for the Bureau of Alcohol and Drug Use Prevention, Care, and Treatment. In this role, she oversees 4 units, including the Recovery Unit, supporting best practice implementation, and a $50 million contract portfolio of OASIS-funded substance use treatment and prevention providers. The Harm Reduction Unit, which funds the 14 syringe exchange programs here in New York City, providing over $8 million for harm reduction services. The Overdose Prevention Unit, which is tasked with preventing opioid overdose, in the city through the distribution of naloxone to people at risk who know someone at risk in the Bureau of Operations Unit, which manages the financial and administrative functions of the Bureau. Gail has a master's in public health from Columbia University and previously worked on cardiovascular disease, obesity, and tobacco at the City Public Health Agency. And I'll be reaching out to Gail with regards to coming to speak at one of my programs real soon. Come on up, Gail.
Was that long? I don't think it was that long. That was really pithy. Long term. I really was there. Yeah, that's it.
Good evening, everyone. So you just heard from Denise about all of the data that we are collecting at the health department. And as she pointed out, we are able to use that data to really respond and develop programming that is appropriate to what we're seeing. So I'm going to talk a little bit about the city's response. So in March, the mayor, as a response to all of that data that you just heard about, announced Healing NYC, which was a major initiative to address the opioid epidemic in the city. It included $38 million in funding for the Department of Health as well as other agencies to address the crisis with a multi-pronged approach, building on funding we've gotten the previous year, as we had seen deaths rise, as Denise pointed out, for several years now. Last year we had funding of $11 million. It went up to $22 million this year, so we are very busy with all of that funding. So this is sort of the 7 main buckets of work that we have been implementing with this money. First, so I'm going to talk about each one of them today. The first one is our naloxone or Narcan expansion. I'll briefly touch on the rapid assessment and response program, which is what Denise mentioned at the end of her presentation. Our judicious opioid prescribing campaign, buprenorphine access initiative, our relay program, which is the non-fatal overdose response system. I'm going to talk about our public awareness campaigns and also about expanding harm reduction services. So, as you can imagine, one of the first things that we have focused on with the rise in opioid overdoses is to increase our naloxone distribution across the city. And I will tell you that we set a goal of 100,000 kits really for next year, which is comprised of about 65,000 kits that the department was going to get out the door, 23 kits to the patrol officers for NYPD, 5,000 for correctional health. We give kits out to people who come to the visit houses. DHS was distributing to shelter residents, and also we were going to increase access at pharmacies. But I will tell you that we are way exceeding that number. This year, our goal was to distribute 55,000 kits, and in the first quarter of this year, we distributed half of those. So we are on track now to do 100,000 kits just by ourselves this year. We're currently finding money to do that. So it's been a huge success. We are dealing with a unbelievable flood of requests for training from all parts of New York City, all different settings, all different agencies. Some of them we're actually being very strategic about because a Narcan kit costs about $90, and we want to really make sure that money is used wisely. And so we actually vet all of our trainings very carefully, make sure that we're actually getting into the hands of people who are at risk for overdose or know someone at risk for overdose, not just everyone who thinks, oh, I should have a kit. So we try to be really strategic with that. As you can see, we're also working with a lot of other agencies in the city and settings that touch people that are potentially at risk for overdose. As Denise mentioned, we also instituted with this funding the rapid assessment and response program, which really responds to real-time data that we receive in the health department. We get data from emergency rooms about what they're seeing, and so if there's an outbreak in a particular neighborhood of a potentially particular deadly batch of drugs, we can actually go into that neighborhood with our staff and talk to the treatment programs in that neighborhood, talk to the harm reduction programs, talk to shelters, any social service organizations that are touching people who might be at risk, and give them the message, hey, there's a deadly drug, more deadly than usual drug out there, and also provide naloxone distribution mechanisms, and really try and saturate that community when we see a particularly bad outbreak. We're also working to promote judicious opioid prescribing. So this is a function that the health department has played for many years, is educating healthcare providers on all sorts of things. In my previous role, cardiovascular disease, we would talk about hypertension and cholesterol. So in this case, we go out and actually use the pharmaceutical model of going into providers and talk about pharmaceutical companies go in and talk about their drug. We go in and talk about our health campaigns. And so we have been for several years now working on talking about judicious prescribing. Here you'll see some tools that we developed about how providers should prescribe opioids and what kind of restrictions they should consider, such as avoiding prescribing for chronic, non-cancer, non-end-of-life pain, shorter duration, and the lowest effective dose. As I mentioned, that's a picture of the front of the detailing campaign, where we go out to providers and bring them tools and information about judicious prescribing. We've done this, as I said, for several years. We've been to Staten Island, the Bronx, and Brooklyn, and this year we're actually expanding to go into pharmacies and talk to pharmacists about how they can join our standing order, which is a prescription that our commissioner wrote, which allows pharmacies to dispense naloxone without an individual prescription. One of our other strategies is expanding access to buprenorphine. Buprenorphine is highly effective. It is one of the gold standard drugs to treat opioid addiction, but it is highly underused. Many providers not that many people have been waivered to prescribe it. Those that have, many don't actually prescribe it, even though they've been waivered. So there's a lot of barriers to address, and we've been doing that on multiple levels. One way is we've been funding federally qualified health centers to implement a buprenorphine nurse care manager model, where they have a nurse on staff who helps facilitate and implement that buprenorphine prescribing in their practice. So we've awarded 7 contracts for that, supporting this model, and we're going to be awarding 7 more in the next couple of months, so we're spreading that across the city. We've also have about 3 or 4 adolescent treatment programs that are now prescribing buprenorphine, and there's sort of like one in each borough at this point that again, it's a challenge to get people to use this drug, so we're working on helping them create networks and find patients and get people up and running on the medication. We're offering free training, waivering for prescribers. We've trained over 400 prescribers so far. We provide technical assistance to providers on how to integrate this into their practice, develop patient and provider materials, and we're also funding syringe exchange programs to do buprenorphine. This year we're going to have 4 up and running, and hopefully another 4 in the subsequent year. I mentioned the Relay program, which is a non-fatal overdose response system. So the idea behind this, if someone comes into the emergency room having survived an overdose, this is a key time to give them messages about how to, continue surviving. So we have a system where the hospitals that we're working with can call us, and we will dispatch a wellness advocate out to the hospital, who's someone who's had lived experience, who will engage with the person who's come into the emergency room, offer them a naloxone kit, offer the person that they're with, if someone came with them, a naloxone kit, and and offer other sort of risk reduction messages, and to connect them to any services that they're interested in, and then ask if we can follow up with them for up to 90 days. And we've had a lot of great engagement around following up with people. The goal is to be in 10 hospitals. We just launched our 4th hospital about 2 weeks ago, Maimonides in Brooklyn. We're also at Richmond University Hospital in Staten Island, Montefiore, and New York Presbyterian. Some of you may have seen some of the ads that we've produced over the past year. These are just a few pictures of some of them. We started out with Save a Life Carrying Naloxone. That's a picture of the Staten Island Ferry Terminal. It was also on buses, as you can see there. We also ran TV ads about saving people's lives with naloxone, and print ads, as you can see, that I saved my neighbor's life. And so we had different stories of different people. We have new ads that are going to be launching November 13th, right? Around with people telling their experiences using being on methadone and buprenorphine and how that changed their life. So the other strategy, actually the last of our strategies that we funded with this funding, was to increase the funding for our harm reduction programs, which are the 14 syringe exchange programs in the city. We were able to double our funding to the syringe exchange programs, which is very exciting. These are programs that work on a very tight budget with very few resources, and our goal was really to strengthen them, build them up. They distribute most of the naloxone that we get out in the city, and they reach people who are using drugs and who are at highest risk, and we really wanted to expand their activities. So we've been working, as I said, to sort of organizationally strengthen these organizations, get them to reach to new geographies and new populations. We've been buying things like a van if they want to do mobile outreach, funding renovations. We have funded a dedicated overdose prevention coordinator to really improve their capacity to provide overdose prevention trainings, and other sort of funding to expand those services. I just thought I'd make a note to talk about what some of the other activities are that this funding funded, besides those at the health department. Health and Hospitals, formerly known as HHC, has also got funding to really completely overhaul the way that they approach drugs, and particularly opioids in health and hospitals. So they're in the midst of a big restructuring. They developed an addiction medicine consult team. They're distributing naloxone in emergency rooms. They're connecting the people who come into the emergency rooms with their treatment providers and offering buprenorphine in many different contexts. So there's a lot going on there. There's also an increase that Rikers has a methadone program, and this funding was helped to increase the number of people on methadone in Rikers, and also increase the number of people on buprenorphine. The Office of the City Medical Examiner and the NYPD lab, which Denise mentioned before, also got funding to increase their lab testing, which really allows us to have some of the data that Denise talked about in terms of understanding what's in the drug supply. NYPD also got a lot of funding to do have established overdose response squads and hire additional detectives. And that is my presentation.
Thank you, Gail. Excellent job. Moving right along, I was trying to figure out some appropriate humor to bring to this setting this evening, which I just, I'm really challenged with that, given the gravity of the situation. But if I do throw in a quip every now and then, please forgive me. I think there needs to be some type of balance, in terms of the darkness and the light. Up next, Alan Clear. Alan is the director of New York State Department of Health AIDS Institute, Office of Drug User Health, where he is responsible for the program planning, design, and implementation related to drug user health, including HIV and HCV prevention and access to care. Alan has worked in the field of drug user health since 1990. He was the executive director of the Lower East Side Reduction Center, one of the first syringe exchange programs in New York State, and of the Harm Reduction Coalition, which is the prominent community-based organization, harm reduction as a mode of working with drug users in the United States. Alan, come on up.
Just had my time cup. Can you believe it? Let's see. All right. Which way is this going? All right. So my name's Alan Clear. I am the director of the Office of Programs of Health. It's a relatively new program. It's about a year and a half old. What it did is bring together all. Go back. What it did is bring together all of the programming that the State Department of Health AIDS Institute has been operating for since 1992, really. So the student exchange programs, pharmacy access to prescription, to syringes and drop boxes, as well as our overdose program, and then I'm going to talk about our hub program too. But we're located within, all the way down there. And basically what Gail said for the city, you can say the same for the state, really, except with less money and more space and territory to cover. So actually it's interesting looking at like Denise's slides, where you see that decrease in overdose rates in 2006. I'm pretty sure we can't attribute any reason to that, but when folks in the syringe exchange programs and everyone started distributing naloxone, it was in 2006, which is when we saw that decrease. And you saw that decrease amongst Latinos and African Americans, which, you know, primarily maybe it may have received those kits back then by the syringe exchange programs. So this is sort of what it looks like in New York State. You see as it gets darker and darker, you see the impact of opioid overdose in New York State. And you know, there's particular hotspots. Western New York, Buffalo is really hard hit. Sullivan County as well, and Long Island we hear a lot about. So, you know, what we've been doing since 2006 is gradually training more and more providers in the community by different disciplines. So community programs, and that's, you know, that's our syringe exchange programs, training people who use drugs, and that was. People who use drugs are the original first responders, putting tools in the hands of people who are actually on the scene. Then law enforcement has been well trained and provides a lot of naloxone and reversals outside of the city. And in fact, this year, in terms of reported usage of naloxone, for the first time, law enforcement have overtaken the community in terms of reporting, not actual. It's debatable, but in terms of reporting, law enforcement now provides more naloxone in the community than the community does. So firefighters, EMS, from school settings, we're in prisons. So Sharon has been instrumental. Sharon Stanford is going to speak in a minute, working with the Department of Health in training in corrections. So people leaving prison, coming home, can pick up naloxone on the way out. And as of yesterday, or very, very soon, we're now in all state prisons. So they don't bother with the, I tried to reformat this and it wasn't worth it. You can see that we've trained close to 200,000 people. Not everything is represented on here because we only started recording figures in 2014, but the green lines are community, law enforcement are the blue bits. So you can see how we really try to get naloxone out into the community as a first line response. And there we are with the administrations. Again, terrible formatting. I was told to reformat it, but I didn't. So there you see the orange reports, that's from community, and the red is law enforcement. And law enforcement actually is a little bit underreported, but they are best reporters because it's part of the process when they, yeah, they have to, as you just now. But not all of them do because they go their own way. But for community, when they reverse overdoses, there isn't actually a particularly helpful way of them reporting. So a lot of reports from the community comes back via syringe exchange programs. If you picked up a kit coming out of drug treatment or getting from corrections, you're less likely to go back to drug treatment or corrections and report that you used it, for obvious reasons. And this is the corrections piece that I was just talking about. So as of very recently, we've now expanded to all the prisons, which is really good. Youth and orphan. So we, buprenorphine, as Gail talked about in terms of its strategy for addressing opioid use disorder, our approach is aimed at the same groups of folks as the city in terms of healthcare facilities, syringe exchange programs, getting into places that weren't normally prescribing or making easily accessible buprenorphine. But from our point of view, it is an overdose prevention strategy. It's getting buprenorphine into people's bodies because if you do that, they're less likely to die of a drug overdose. And we are much less concerned about the opioid use disorder treatment piece of this and giving people the option to take buprenorphine as a respite, or they can take a break from their heroin use, they can take a break from being out there in the economy buying drugs and not knowing what's out there. And if they like it, they can keep using it. We use, for example, in Ithaca, one of our programs that we fund, the person who was prescribed and filled their waiver, filled that limit of 30 people in 3 days and had a 60-person waiting list. But every single one of those people who got buprenorphine from that program went on to do other things, like going back to work and getting their lives together, rather than like a more treatment model of like a lot of psychosocial support, but people did choose to get that also. This is actually a breakdown of how, on the right here in the blue, places we're trying to get buprenorphine into. But the bit on the left about prescribing practice, we're trying to, as we do this work, we're doing some of the trainings, we are providing technical assistance and guidance to people who are waivered, and we're trying to talk to providers that there needs to be a shared decision making in terms of working with people who use drugs around the buprenorphine and how they use it. We encourage non-punitive response to other drugs in people's systems. The whole notion of piss testing is really to see if people have buprenorphine in their system, and anything else, it's a discussion point. It's not something for to be used in a punitive way. We encourage home induction to make it easier. People who use drugs are very good at taking drugs. You can go home, take the medication with you. You don't have to sit in a room, go into withdrawal, and you can do it at home by yourself. So, skip that. So talking about the hubs, this is similar to what Gail talked about in terms of providing increased funding for our syringe exchange programs. The syringe exchange programs are people who want to see people use drugs. They're not indifferent, that's who their population is, whereas most other people want to keep people who use drugs out of their services as best they can. So by enhancing services and funding to our syringe exchange programs, we're encouraging them to look at the totality of people's lives and connect with people. Because a lot of what this is about connecting with people who are disconnected. So we're talking, again to the city, getting connections with emergency departments. Our program in Buffalo gets referrals from the emergency department from folks who have overdosed. Law enforcement connections in Albany, one of our programs works with law enforcement assisted diversion. So we provide the support for expanded hours so that Albany PD can get people over the program, connect them with EMS, family when they run out of ideas as what to do, they can send people to our programs. And in the programs, actually, next slide, we're thinking about how, some core elements of syringe access, easy access to buprenorphine, naloxone, hepatitis C care, because we can now treat and cure hepatitis C. But it's all done in this kind of surrounding where there's multiple services available to people who use those programs in a stigma-free environment as best we can. Because, as I mentioned, so many other services are provided. Services are limited because of stigma, and it's one of the big barriers that people who use drugs face in accessing any kind of care or support. And I think that is, that's where the hubs are. So the first four were Buffalo, Ithaca, Staten Island, and Albany, and now we've expanded to 11 around the state. And hopefully, at some point in the future, we will expand to all of our 23 syringe exchange programs, soon to be 24 actually. Oh, NCAP. So, this is one of the things we've recently done as was mentioned, it's expensive to provide naloxone. Naloxone's not free, we pay for it. But what we've done is figured it out so that if you have insurance, you can basically go to any pharmacy and get your copay paid for in New York State. But certainly in New York City, you're probably able to pick up naloxone using your insurance, and you will not be charged for it unless your copay is over $40. So there are some little handy-dandy information sheets down here. So unless you don't have insurance, and if you don't have insurance, we will provide you with naloxone. We still prioritize syringe exchange programs and people that use them, but if you are a person who is interested in having naloxone, we recommend that you go to the pharmacy and pick it up. And that will encourage pharmacies to keep naloxone on hand. And there you go. And there you go.
Thank you, Alan. You did magnificent with regards to the time constraints. I'd like to invite up Sharon Sandliff. Sharon Sandliff Cliff, MD, is the Medical Director of the Harm Reduction Coalition. Thank you.
Not that one, not that one, not that one.
Which is a small national. Should I use one of those up there?
So the Harm Reduction Coalition is a national training and advocacy organization that works on helping people that use drugs get social justice, get training, get harm reduction. And so we're kind of in that space that Alan began to talk about. We're not about preventing drug use. We're not about stopping people from using drugs. We're that weird area in between where most people lie. And we're funded by both the City Department of Health and the State Department of Health, where we went. So I got the leftovers here, because they talked about some of the stuff that we do already. I have a question. How many folks here feel like they know people that are at risk of overdose, or perhaps have known somebody with an overdose? That's what I expected, lots and lots of it. So I want to use some of what we've learned today and tell you some of the stuff you can do that may not have come clear. First of all, we talked about syringe exchange programs. Do you guys know where they are in New York City? You can see it on the City and State Department of Health. But you can also go to most any pharmacy in New York City and buy 10 syringes. So tell your friends, we don't want anybody to have to share a syringe. They go down to the pharmacy, they might cost $1 each, they might cost 10 cents each, but you can buy syringes at pharmacies and walk away with them. Nobody should share a syringe. So if you don't know a needle exchange or you're shy to go in, there's lots of other things. The next thing we're going to have is the naloxone training. So everybody here that is at risk of seeing somebody have an overdose will have the antidote to reverse that overdose right then. That's the first step. You know, some people say it's a Band-Aid. I love Band-Aids. I put them on my blisters. I do lots of things. It's an important step to save that life, even though they might overdose again. And then everybody began to talk some about buprenorphine. Do folks know what buprenorphine or methadone is? So this is a medicine. It's basically an opiate that you take every day, but instead of getting high from it, unless you choose to use it in a different way, one feels normal. Now we've always talked, this is a brain disease, this is a choice, is that, we definitely know it's not a criminal disorder. I don't really care, I'm trained in family medicine, I just want what works, I don't always have to explain it. I don't really care what we call it, but we know that when people have easy access to buprenorphine or to methadone, especially buprenorphine because it's really hard to overdose on, they're 80% less likely to have an overdose and die. They may want to do lots of other things. They may want to do counseling. I know we have people in this room that represent lots of other avenues towards recovery or towards simply not using drugs. Not everybody who doesn't want to use drugs anymore talks about recovery. But I feel like this is the key right now that we've got. to preventing people from dying of overdoses. So notice on this little slide I've got up here, what's the last thing I've got there? I mean, you want to prevent death, you want to prevent disease, you want people to be able to live normal lives. We had a beautiful presentation at a conference yesterday. Somebody got it said, I'm amazing, I'm still a drug user. This is my life, I've got a job, I've got a family, I've got a husband. Some of you know this person. So this is what we want and what we sort of box in as treatment. When you think about drug treatment, you think about abstinence? Yeah. It doesn't have to be. Abstinence is great. Lots of my friends are abstinent. But we can keep people alive, not using some drugs, not using all drugs, maybe having just one drug, maybe just using sometimes. I had a patient that used on weekends. Did buprenorphine during the week. He sort of stopped using after a while because he liked having the money in his pocket better than he liked using heroin. So I just want to spread a little bit of sort of, this is the harm reduction outlook on it rather than tell you all the things that we do. I did bring some graphs and some stuff like that though. So I'm going to just skip right ahead to Baltimore. We know that when we get buprenorphine into the community, and I could show you Vermont, I could show you France, I could show you Norway, we know that when people get access to this, it's associated with a decrease in deaths. Now, probably some of you out there will say, there's lots of other reasons why it could be true. I can't prove it, but I could show you numerous places. This is Baltimore before fentanyl came. Fentanyl really has been a game changer. But the red line is overdose deaths, and the dotted lines are access to methadone on the top and buprenorphine, which started in 2002. Really dramatic change in deaths. We could do that too if we can get over the regulations about buprenorphine and our preconceptions about what drug treatment looks like and our stigma about the people that are taking the opioids. I wish it could be as easy with some of the other drugs that are killing people. This one's the most deadly one right now, but we can do this. We really can. You're going to tell me 5 minutes, right? So I was asked to talk about 4 things in 10 minutes, so I'm only going to talk about a couple of them. So that's buprenorphine, and just put that away for your friends that might be using. I think you've got a really cool health center here. Anybody know if there's somebody wavered? Thank you. In there in the clinic? Yes? Well, if there's not, if there's anybody in the health clinic here at the new school, yay! And you are the first and only school that's delivering naloxone in your health center. That's so I'm working a little bit with folks to begin to maybe change that. Good, here I do. Then I was asked to talk about supervised injection facilities. Have people heard of that? Been reading about it in the news? So I just want to say a few things about it because they're being used in other parts of the world to prevent overdose. There's 3 ways that we can prevent, that we have proven to prevent overdose. One is giving out naloxone, which is going to happen in a little while. One is providing people with access to methadone and buprenorphine. Methadone's great too, which is even more restricted, even more stigmatized. But the third one actually is the presence of supervised injection facilities. They are, of course, illegal in the United States right now. But we need to, things start somewhere. We need to learn about them first. So I decided to use a couple of my notes to talk about those. What we're looking at is a really high-tech supervised injection facility in Vancouver. All those little booths are where people can go and very, very cleanly use the drugs that they bought on the street. They may not be clean drugs, they may have fentanyl in them, but there's people behind that counter. They're giving them equipment, giving them advice. They won't shoot up for them, but they will give them all this advice and give them a place to hang out and give them a smile. Walk in and you'll actually have somebody that says, "Hi, Joe, how are you today?" Which can happen lots of places, but for many people, there's not many places. So that's the really high-tech one. There's ones that are just, I went to one in Rotterdam, it's the basement of a church, it targets immigrant populations, and it's like some, a few desks and then some couches. So they come in a lot of shapes. There is an article in, I forget which journal, about an underground one, an undisclosed place in the United States. That, they did an evaluation. All of these places see overdoses. Nobody has ever died in a supervised injection facility. But I do want to say, this is their goal. They were sort of set up for public health. Their main goals are to provide a place for safer drug use, improve the health status of the target group, and reduce the amount of syringes in the neighborhood. And they've been shown to do these things pretty clearly. And again, nobody's ever died of an overdose inside, and the overdoses in the immediate neighborhood have been shown to go down. So, I just kind of want to plan to see and give you a little bit more background on what you might be reading in the popular press. I also want to say they're not a panacea. We need many things. These target the folks that are really some of our most vulnerable population. And I don't have the quote in my head, but there is this concept, how we treat the most vulnerable amongst us is how we can begin to judge how we are as a society. So I'm incredibly proud of the prison project that Alan talked about. We've actually almost got double with the new prisons coming on, pretty close to 8,000 people formerly incarcerated carrying naloxones that are probably saving lives without telling anybody. But this is just sort of a little list of the population that's targeted. It's mostly men, it's mostly men, in the 30s, but most of them are housed insecurely. People don't leave their nice apartment to go and supervised injection facility, I don't think, not that I've seen. Most of them have been many have been incarcerated, many participated in sex work, many have they've had pretty rough lives. So this is another intervention. None of them fit all sizes, but we really need to make use of what we can now, which is naloxone and buprenorphine, and we need to expand to this and other things that I don't have time to talk about. Thank you.
So our next speaker is one of the key organizers for this program this evening, and with his permission, I am going to forego the long introduction. What I will say is Andrew Tartowski has been championing this whole idea, this movement of a harm reduction as integrated harm reduction as another tool to apply to helping people to save their lives. Andrew, come on up. Andrew Tartowski.
Thank you. So when Jen and I were sort of cooking up the idea for this day, one of the things that inspired us was that we, recognized, how do I advance this? Unfortunately, it's taken the opiate crisis to move into white communities and middle-class communities to get the attention of the country. It's a sad, unfortunate fact. But maybe we can turn that sad fact into a hopeful, response that will address the needs both of the white communities and the communities of color and poor communities, as witnessed by this amazing panel. And so we feel like there is something very hopeful that will come out of this terrible crisis. As a psychologist, as an addiction person, as a harm reduction therapist, what really inspired me to suggest that we get this gathering going is that, as we've heard today, there's been an increasing and hopefully massive embrace of public health harm reduction efforts to reduce opioid overdose and save lives and really put efforts into all of these other life-saving harm reduction services. But it occurred to us that those life-saving and health-saving interventions really need to be tied to a comprehensive continuum of care that integrates medical, mental health, and substance use services, but wrapped in harm reduction principles. Because as we heard, Alan was just speaking to the fact that most of our health services are still ensconced in or infused by stigmatizing views of drug users, and really, I think, a wrong understanding of problematic drug use and how to be helpful. So if we save, reverse an overdose but we don't have the skills, the personnel, the continuum of care to engage that person in beginning moving in a positive direction, we lose tremendous opportunities that we otherwise can have if we think about needing to transform the system. So one of the things that I've been thinking about, and we've been developing at the center and with our colleagues, harm reduction therapy colleagues, is the notion that we're in the midst of a scientific revolution in the sense that there's a new evolving model that we need to embrace to understand the complexity of problematic substance use, the spectrum of problematic substance use. So we're moving from a model that we were all kind of ensconced in, which is the old disease model, in which only abstinence is the acceptable goal, toward what we're calling and thinking of as a complex psycho-biosocial process that contributes to problematic use, and also helps us understand why the majority of folks, I think, no, I'm sorry, how do I get this going? Oh, just there, like always. The majority of problematic drug users are not ready, willing, or able to embrace abstinence. And as a result, since most substance use and mental health treatment and even medical health treatment is presuming that if you've got a problem with drugs or alcohol, you need to think about stopping, that really turns people off from seeking help. So our challenge is, how do we create a treatment system, a continuum of care that is actually appealing, is relevant, and is effective at helping begin their process. And you know, there are many people who want to stop one drug but don't want to stop another drug. And actually, I'm sad to say that I keep hearing every day that major, well-respected treatment programs in New York City still won't take people who want to stop using crack or heroin but don't want to stop smoking weed. It's a bizarre notion to me, but that's sort of the state of the art. So what is this new model? I think we need a more complex model. The disease model says the disease is permanent, chronic, and progressive, and only arrested by complete and total abstinence. And you can't begin your recovery until you've accepted that and embraced abstinence. And so that model is a model that doesn't work for the overwhelming majority of folks, and informs a treatment system that most people don't want, and doesn't help most people that get in it, and actually, I think, traumatizes many people who are in that system. In fact, the data, and you know, we can't go into all of this in depth, I have probably 7 minutes left, but it seems to me that it's more useful to think about the fact that there are multiple vulnerabilities, psycho-biosocial vulnerabilities, that interact in ways that are unique for each person, that contribute to their vulnerability to use a substance and get into trouble with that substance. And as people use chronically over time, there are multiple psycho-biosocial factors that contribute to the escalation of the use, including the fact that we live in a society that stigmatizes and criminalizes drug users, leaving them feeling worse, feeling ashamed, feeling guilty, feeling like they need to hide, isolate, which is only going to compound the initial vulnerabilities and contribute to escalations in use and the increased risk of overdose. But what does this imply for treatment? First of all, it helps us understand why most people who are struggling with their drug use don't want to stop, because in some ways it's still helpful. And that's the dilemma that most problematic drug users are living with. That's where we need to meet them. That's why we need a treatment system of mental health care, of substance use treatment, that's informed by harm reduction principles. And that's why we might say that the majority of folks are in pre-action stages of change. So it seems to me we need to have treatments or helping relationships that engage people in pre-action stages of change and around non-abstinence goals. That's the majority of people who need harm reduction informed helping. Now, what do we mean by that? You know, most people think harm reduction is the strategies. I think that harm reduction is basically a philosophy, a set of principles, an attitude, a way of being with people or being with oneself. Compassionate pragmatism. We need to first and foremost consider helping people heal and improve the quality of their lives. and accepting that we need to start where people are. We shift from abstinence only to any place that a person is ready to begin a positive change process. That's where we need to meet them, on their terms, around what's important to them, around what motivates them, and we need to meet them there, meaning we start where they are, around any positive change, and we work collaboratively as a team to empower people to begin moving in a positive direction. So harm reduction is a philosophy that we could think of as an engagement strategy. It frames helping relationships. I like to say we don't need to know the destination to begin the journey. So we've been hearing about harm reduction settings, and Alan has this beautiful, maybe very pragmatic idea. We need to move all the services into the harm reduction settings because all the other settings don't do it very well, right? But we also need to train folks in those settings and hopefully in those other settings in a way, in harm reduction principles. And I know many well-established, long-living harm reduction agencies don't really have necessarily a coherent understanding of what that is. So I think we need to bring a harm reduction orientation, rather a therapeutic orientation, a healing orientation, an engagement orientation into harm reduction settings. And we need to bring that harm reduction orientation into treatment settings so that harm reduction is sort of the wrapping that wraps the entire continuum of care, from syringe access to comprehensive, integrative health care, including medical, mental health, and substance use. And so there should be no wrong door. People should be able to walk into any door and be greeted by a harm reduction helper who can then do an assessment and collaboratively figure out a comprehensive plan that starts where that person is. I think I have 90 seconds left, but so our treatments need to be looking at the body and need to be primarily thinking about medications, particularly when we're talking about people that are opiate dependent, but we also need comprehensive, integrative psychological care for the issues that either preceded and left people vulnerable to problematic use or result from the traumas of being a drug user and having been traumatized by treatment, by the police, by health care that kicked them out. That needs a psychological therapeutic intervention. Obviously, we need social community services, and it all needs to be framed within that harm reduction framework. Finally, this is our approach to harm reduction therapy. We think that there are a number of different interventions that we can train people. In fact, we're doing a 3-day training. This is my one pitch here at the new school, December 1st through 3rd, where we're training people in this comprehensive therapeutic model that's informed by harm reduction principles every step of the way. Just simply put, the first task is to engage people. Therapeutic alliance, create safety. How do we do that? We begin where people are with respect, compassion, support, collaboration. Then we create a relationship on their terms. And then we set about helping people cultivate the capacity to sit still with their discomfort, self-management, self-regulation skills. We can then collaborate on our assessment, working together to figure out what are all those complex factors that are unique for that person, including working with their ambivalence about changing. So we invite people who don't want to stop using into the room to kind of, explore their ambivalence. Now, out of that ambivalence, we can start talking about positive change goals around substance use, integrated with all of the other issues that are intertwined with substance use, and we can come up with personalized plans that are uniquely tailored to each individual. So I think, just in closing, to repeat what I said at the beginning, I think all of these really important, powerful strategies that help people save lives need to be informed by and framed by a harm reduction attitude that is anti-stigma, and that really is about creating safety and creating safe spaces where people want to come in to get support. Thank you.
Thank you, Andrew. Andrew Tarkowski and all our speakers up to this point. Up next,
I don't have slides, PowerPoints, all over me. I'm going to do my best to try and not use colorful metaphors that I usually do when I use metaphors like shit, the F-word and other stuff like that. So, and this thing keeps coming off. For those of you who don't know, my name is Robert Suarez. I am a vocal leader. Vocal New York stands for Voices of Community and Activist Leaders. All right? Not only that, but as you heard, I'm also a board member for a global network that stands for INPUT, and the acronym for INPUT stands for the International Network of People Who Use Drugs, as well as a North American representative for North America. What all that means, I don't know. I just know that when it comes to saving lives or people who use drugs, I look at them as people who deserve to live, right? They're human beings. That's where I'm at. A little bit about me and why I'm here. My mother was an intravenous drug user. And when my mother was carrying me, she was using. My mother died in the year 2000 in my arms in Harlem Hospital from the complications of AIDS that she contracted while using. A little bit about me, right? I came into this thing of ours, what I like to call harm reduction, from under bridges, under highways, in the backs of parks, right? Using and doing all the other things that we little drug users like to do when we're stigmatized, right? Really quickly, when it comes to when it comes to that stigma, it is the most dangerous thing out there for individuals who use drugs, or anyone else for that matter, right? When it comes to stigma about people who use drugs, drug users, I like to look at them as the haves and the have-nots. The have-nots are the ones that everyone sees, the dirty people, people with no clothes, the people who are homeless, the people who are on the street, people who are nodding out on your corner. Those are the have-nots. Then you have the haves, the individuals who have their condos, their townhomes, their ivory towers. You don't see them. You don't see them. They're in their homes. You can afford to be in their homes. And those are the ones who are not stigmatized. And they're dying at the same, just about the same rate as the have-nots are dying. There's the ones who are on the corner that doesn't have it, that everybody seems to say, oh, fucking dirty drug user. Get them off my corner. My friends, let me tell you about those individuals. Because I was one of them. Just because it looks like I just came from Greenwich Village, having a cup of tea, don't get this twisted. Right? Because I switch up and I put my Timberland boots on with my jeans and I look just like the rest of the people. Drug users are amongst the most talented, gifted, and blessed individuals on the planet. Let me say that to you one more time. Drug users are amongst the most talented, gifted, and blessed individuals on the planet. I was raised, I was loved, right? But somewhere along the line, I took a wrong turn, right? I wanted to use, and I started using. I wanted to hang out with my friends, do everything else. That led me to being in the back of parks and on the bridges and everything else, right? I play classical piano. I've done Broadway. I've done off-Broadway. I've done off-Broadway. No, I'm being very serious. I even sing. When I tell you that drug users are amongst the most talented, gifted, and blessed individuals on the planet, I'm being very serious. We cannot afford to lose not one of them. A drug user will bring you loud. A drug user will bring you a work of art. A drug user is the individual you see up on the TV screens or on the movie screens when you go to pay the money, right? These are the same individuals. These are the haves. And we're losing them at the same rate as the have-nots. When it comes to drug user organizations like Vocal New York, organizations like Vocal New York is a grassroots organization. And they are building power within low-income communities, taking individuals like me and giving them a voice. Taking individuals like me and making sure that we understand that we are not to be left behind. We are a force and a voice to be reckoned with. You will hear me. You will understand what it means when I say, no more. No more will you stigmatize me. No longer. No longer will you shut me out. We're the voice. We've got all our scientific community backing us up. We've got our medical community backing us up. We've got our researchers backing us up. But still, individuals are saying, oh, no, let's see if there's something like my place. You don't want that here. I had the pleasure of traveling to Switzerland. A gentleman who's sitting in this room right now, I'm not going to mention his name, no, I'm going to mention him, Alan Clear, called me up one day and said, Robert, you have a passport? I said, Alan, I live in the hood. We don't have passports. He said, Robert, I want to send you to Switzerland. I said, Switzerland, where's that? He said, Geneva. I said, Geneva, where's that? He said, Geneva, Switzerland. I said, for what, Alan? He said, I want you to speak at the UN. I said, no, Alan, you gotta stop this. You just can't keep throwing my name out there like that. Anyway, long story short, this individual came from one of the bridges on the highways in the back of parks, got on his first international flight, flew to Geneva, Switzerland, and spoke at the United Nations World Health Organization headquarters, and slammed it. For whatever reason, don't know. Right? Now, I had the pleasure of visiting a safe consumption site while there. And believe it or not, it was in downtown Switzerland. So I asked him, I said, well, why did you put it in downtown Switzerland? And they told me, because we are not so naive as to believe that people who use drugs don't work too. That's not some deep shit. That's deep. We know that we have professionals who leave their little urban homes, drive into the city, right? They need to get off so that they can go and get some good work done. How about that? The United States is considered to be a third world country when it comes to health issues like this. When it comes to public health issues. I had the privilege of also going up to other places around the world as a board member. I've been to Geneva, I've been to, oh God almighty, London. I've been to London. I've actually had the pleasure of sitting at the UNODC, all right, and Vienna, Austria. I'm standing around a bunch of health professionals, and they say, hey, where are you from? I said, I'm from the United States. And they literally said, well, I'm sorry. I'm sorry, sooner or later you guys get your shit together. And this guy from the hood has nothing to say but, yeah. Eventually we will get our shit together. Now, when it comes to moving forward legislation here in New York City, Vocal New York does it like no one else does.
Right, yeah.
Right? Vocal New York, the voices of community and activist leaders, does it like no one else does. We will shut government down. We just recently got a bill passed, 1443, which calls for having naloxone in city shelters, and not only just the staff being trained by naloxone, but the residents, the first line providers being trained with naloxone. And you want to know how we did it? We shut down the street, Broadway. We shut down Broadway, leading to City Hall. We have police commissioners, deputies, and everybody else out there. Guys, can you please move? We're looking at them like, no. Traffic backed up for 5 miles. Before they could arrest us, we disappeared. That's how we get down. Next thing we knew, they were ready to include the language that says residents also must be able to be trained and respond when it comes to an opiate overdose inside city shelters. I'll just lead them cause of death inside city shelters. These are opiate overdoses. Ladies and gentlemen, my friends, people, let me tell you one more time. When it comes to individuals who use drugs, we, and I say it, we are amongst the most talented, gifted, and blessed individuals on the planet. You cannot afford to lose not one of us. Not one of us. Last thing before probably, I don't want to go over my time or get close to my time. When it comes to the word addict, it's a word that I and many, many others find to be offensive. It's offensive, it's harmful. If you're working to prevent harm, let's get rid of that word, addict. People who use drugs, drug users. Addict has been stigmatized and does nothing but cause more shame. Is everybody with me on that so far? Yeah. Everybody with me so far? Thank you. Now, I want to make sure, because I'm not sure if I'm preaching to the choir or not. And I don't like really preaching to the choir because the choir already knows. Everybody at Pennsylvania, I didn't know that. How many people in the back are users? Okay. Nobody. So, how many people in the back have ever used marijuana? All right. Cool. So, how many people in the room have ever used cocaine? All right. How many people in the room have ever used heroin? You know what? I'm so honored to be in this room of individuals who are able to say, you know what, I'm a user. I'm a user, and I'm alive. I'm alive. So many people today are afraid to admit who they are. That's what keeps the stigma going as well. That's one of the things that keeps people going as well. Really quick story before I shut this down. Seattle, Washington, in restaurants, in the U district, if you walk into that restaurant, any restaurant, you talk about drug users outside that restaurant, walking up and down the street, individuals inside that restaurant will say, you know what, we don't do that here. Let's continue to move forward with that kind of concept. My name is Robert.
Thank you, Robert. I'm going to keep coming around because I'd like to hear more of that story. There's a lot of identification there. We have two presenters representing the new school, Student Health Services, Tracy Robin and Kevin Franciotti. I'm going to invite both of them up and allow them to introduce, tell us a little bit about themselves and do their presentation. We are just about where we need to be, folks, in terms of time. So if Kevin and Tracy can come on up, you're here.
My name's Tracy Robin. I work here at the new school. I'm in the Student Health and Support Services.
Sorry, damage control. Robert really fired up the crowd, which was very empowering to hear. Definitely woke me up. A good shot of harm reduction, passion. And just looking around the room, very empowering, knowing that there are people here who have certainly lost a loved one to an opiate-related overdose. There are people here who want to do something about preventing loss and further life as a result. And this is the type of drug education that I wish I received when I was younger. So I'm going to talk about my experience a little bit before we lead into this presentation. To borrow a line from Mitch Hedberg, I used to do drugs. I still do, but I used to too. A little one-line zinger. But I was not a harm reduction user. I was not a person who learned the tools. I'm a graduate of the DARE generation, and the one thing I had to do was say no, and I failed that. So I wasn't equipped with any other tools to know what to do because I said no. I tried to figure them out all by myself. I tried to look to the people older than me who were doing the behaviors that I wanted to do and was curious about. And so I spent about 8 years just kind of becoming introduced to this drug and that drug, and which I liked more, which I liked less. I came from a have family in middle-class neighborhood in Long Island. And that embraced alcohol as a socially acceptable drug that we could do and talk about. Anything else, no. And if I did it, I couldn't talk about it. That's the way I felt, at least. And it created a divide between not only myself and my parents, and even in some cases my siblings, but also my teachers, other resources in the community who I just didn't feel like I could trust anymore. So created a very bad environment for me to run into as I started to come of age, and trauma experienced in my life really seeped through to my unconscious drives and motivators to get out of myself and get away from some of the pain that I couldn't deal with and didn't know how to deal with. So when I was introduced to opiate painkillers, it was not from a legitimate prescription, despite the common narrative that somehow that is how everybody's becoming addicted to heroin. My experience was buying prescription painkillers from an unlicensed provider, aka my local drug dealer. So when those became too expensive, and I then switched to taking heroin intravenously. And again, being so ill-equipped to understand our basic harm reduction principles, about 8.5 years ago, I remember just wanting a really powerful hit and mixing up like 8 bags that I got from a guy in Brooklyn, because they weren't in my neighborhood, I didn't think. And I came to X amount of minutes later with the needle still in my arm, with my head dangling off the foot of my bed in my parents' house, and being completely out of it. And I came to look out the window and see my mom pulling in the driveway, who, my bedroom door is wide open. 5 minutes later, that could have been the scene that she walked in on, and not only would I have been outed in that moment, but that would have been a very traumatic and devastating experience for her. Her son of privileged means is not one of those people who goes through this, and in her own lack of education to be ill-equipped to then know what to do. But instead, I had the luxury of my interveners being the Nassau County Police Department on more than one occasion. And I've been arrested, I think 5 times, and I don't have a criminal record. And I can really only owe that to the color of my skin, the family and background that I come from, and the resources that we have. I've been charged with misdemeanors and felonies, and I still cannot, I don't come up on a criminal record. And that introduction to recovery was eventually through the treatment court system in New York and Nassau County, which I was not ready for abstinence at the time. I was not willing to do that. I understood the risks of rejecting that treatment option, but instead I continued to use heroin and perpetuate my use disorder despite that, just waiting till eventually it goes away somehow. But instead, the kind of compassionate moment that finally enabled my mother to get through to me was just coming into my bedroom one night, asking me if I'm okay, with no agenda, just pure love and compassion and comfort. And I said, no, I don't know if you know this or not, but I've been using for the past 10 months. I barely speak to anybody, and I stay up all night and hide in the corners and in the shadows. So she said, what do you want to do about it? And I said, well, there's this alternative treatment that I would really like to do, called ibogaine. For those of you who don't know what ibogaine is, it's derived from a shrub in West Central Africa. It's been discovered in the early 60s by a man named Howard Lotsoff right here in New York City, who took it while an active heroin user. And coming out of this experience that he had, just a friend offering it to him, discovered that he didn't go through withdrawal despite not using heroin for a prolonged period of time. And not only that, but he had no craving to use it. So I embraced that treatment as an alternative to the dominant 12-step model that I had rejected the year before, but was still the only pathway that was being offered to me for recovery. But in 2011, my family of means decided to roll the dice and send me to Mexico, in a country where I could legally take this in a clinic that was had medical staff, was very safe to use, I was properly screened, and after this, really what it comes down to is a detox treatment. I had a very powerful psychospiritual experience that provided an incredible visionary journey. I was, the withdrawal that I should have been experiencing was attenuated, and in the months and weeks afterwards, I had very minimal craving to go back out and try to use again, but I had also further means to then embrace this abstinent offer through the drug court for my active charge. So I went to South Florida, I completed their program. Somehow they allowed me to complete it in Florida, convincing them that if I moved home to New York, I wouldn't make it. But after a year, I got my life back, so to speak. I returned to school in Northeastern, and then that was just a few years ago, and now here at the new school where the wonderful harm reduction-oriented program started here and under Professor Gentali and her class embraced the idea of becoming a treatment provider. And meeting Tracy in the health center has enabled me to bring these trainings to students on campus, to staff, and really giving me a shot at providing education and resources for people like me who may not have been introduced to that at the right time. So with that, I will lead into the actual training component. There's still a microphone here? Okay. So the goal of this training is to prevent death and other negative consequences of opioid overdose. This picture was familiar from Lisa's presentation, or Gail's. So here at the New School, we're the first university to register with the New York State Department of Health to become an opioid overdose prevention program as of July 2015. So under Tracy's pioneering work and others in the health center, we provide this training to residence halls, students in the graduate school, and really any student that comes to, I think we have about one per semester of training that tomorrow heads. So the learning objectives, in addition to the learning goal, is to be able to list the 4 risk factors for overdose, recognize 3 signs of an overdose, and properly identify and respond to an opioid overdose using intranasal naloxone, which we will also be providing to people who want. So we had some data presented about New York City, New York State, and we actually have a little bit of data about the New School. In a survey that came out last year, we were asking students within the past 12 months, have you taken prescription opioids or other prescription pain, prescription medication, or heroin? And the reference point for fall 2016 is shown, and the difference between 2015 and 2017, that top row there is the prescription painkiller reported use, and then below that was heroin. So it's a bit higher than the reference point for other colleges. Yeah, so it's a nationally representative college. So what are opiates? I think at this point most people know that. They're used to relieve pain, may cause euphoria, but they also repress the urge to breathe. So opioid overdose often happens when respiratory depression ends up with somebody stopping to breathe. These are a list of the commonly used opioids, and these are some pictures. What is an opioid overdose? Very simply, it's basically when the brain and the opioid receptors that are contained therein get an oversaturation of opiates on those receptors and cause this syndrome. The physiology of such is slow breathing may stop, the heart may stop, and thus the circulation of blood to the brain may stop. This process generally happens over the course of 1 to 3 hours. The stereotype of a needle in the arm, suddenly they're out, only occurs in about 15% of overdose deaths. The observable signs of overdose, however, were a heavy, uncontrollable, nodding kind of dose that may not necessarily be overdose. The person could still be arousable. They may be snoring or breathing loudly, and they may be drooling, or hearing that they're falling asleep or falling down. An overdose is when they're not responsive. There's very shallow breathing, possibly gurgling as they're struggling to breathe, and the skin changes color, the inward purplish lips and nail beds. Fatal overdose on the far end of the spectrum is very slow or shallow or no breathing, bluish or purplish lips, and the nail beds resulting from lack of oxygen, and a very heavy nod, not responsive to any stimulation. So the risk factors for overdose is changes in loss of tolerance. Maybe somebody who's just coming out of jail or rehab, abstinence, and they spend 30 days getting their tolerance down, they go out and use and go out. Mixing drugs, mixing with alcohol or other depressants, varying strength on continence-free drugs, as we've seen repeatedly in the fentanyl proliferation, or serious illness to physical health, general medical conditions, and using drugs alone. So obviously increases with mixing, combining with benzos or other types of depressants. And now we have the quick video that just basically shows the gist of what we're handing out and how to administer it.
Narcan nasal spray is not a substitute for emergency medical care. As with any drug, you need to be aware of important safety information concerning its use. Please see indications and important safety information at the end of this video. Also, please see accompanying full prescribing information in the use of this product. Narcan nasal spray is an emergency treatment for a known or suspected opioid overdose. The appropriate use of Narcan nasal spray can help you save a life. Narcan nasal spray is not a substitute for emergency medical care. As with any drug, you need to be aware of important safety information concerning its use. If you encounter someone who is unresponsive and you suspect an overdose, first shake their shoulders and shout their name. Ask if he or she is okay. Check for signs of an overdose, unresponsive to touch or voice. Breathing is slow, uneven, or has stopped. Snoring, gasping, or gurgling sounds. Fingernails or lips are blue or purple. Administer Narcan nasal spray as quickly as possible if someone is unresponsive and an opioid overdose is suspected, even when in doubt, because prolonged respiratory depression may result in damage to the central nervous system or even death. Lay the person on their back to receive a dose of Narcan nasal spray. Remove Narcan nasal spray from the box. Peel back the tab with the circle to open it. Remove and review the printed quick start guide inside the package. Hold the Narcan nasal spray with your thumb on the bottom of the plunger and your first and middle fingers on either side of the nozzle. Do not press the plunger to test or prime the device. If you do, you will waste all or part of the dose of medication. Tilt the person's head back and provide support under the neck with your hand. Gently insert the tip of the nozzle into one nostril until your fingers on either side of the nozzle are against the person's nose. Press the plunger firmly to give the full dose of Narcan nasal spray. Remove the device from the nostril after giving the dose. After you have given this medication, seek emergency help right away. Narcan nasal spray is not a substitute for emergency medical care.
I'm with somebody who stopped breathing. I think they had an overdose.
Move the person on their side after giving Narcan nasal spray. If possible, put their hands under their head and bend their upper leg forward. This helps prevent the person from rolling onto their stomach. This is known as the recovery position. Continue to watch the person closely. If they do not wake up or respond to your voice or touch, or if they do not seem to be breathing normally within 2 to 3 minutes, use a new Narcan nasal spray to give an additional dose in the other nostril. Acute opiate withdrawal symptoms may occur from use of Narcan nasal spray in patients who are opioid dependent. Symptoms include body aches, diarrhea, increased heart rate or tachycardia, fever, runny nose, sneezing, goosebumps, also known as piloerection, sweating, yawning, nausea or vomiting, nervousness, restlessness or irritability, shivering or trembling, abdominal cramps, weakness, and increased blood pressure. When the emergency is over, put the Narcan nasal spray back in its box and throw it away in a place that is away from the reach of children. In addition to watching this video, please read the quick start guide that comes with Narcan nasal spray before using it. Talk to a healthcare professional if you have any questions about how to administer Narcan nasal spray. Please read the indications and important safety information that follows. Store Narcan nasal spray at room temperature between 59 to 77 degrees Fahrenheit, 15 to 25 degrees centigrade. Do not freeze Narcan nasal spray. Keep Narcan nasal spray in the box until ready to use. Protect from light. Replace Narcan nasal spray before the expiration date on the box. Keep Narcan nasal spray and all medicines out of the reach of children. Indications. Narcan.
My apologies, that is a commercial from the drug company. But we normally would use the Department of Health. That's a really good video. It's a little bit older, which we've talked about, and so we wanted to show something that showed the type of Narcan that we're giving out today if you'd like to receive it. So there wasn't any confusion. So quickly, naloxone usually acts within 2 to 5 minutes. If somebody is opioid dependent, as the video mentioned, they will start showing signs of withdrawal symptoms. They will not be pleasant, but you will have reversed an overdose. It does block the effect of all the opioids in the system, but it only lasts for 30 to 90 minutes. So that's why calling 911, getting EMS there is crucial, because you've prevented the overdose that they need for the treatment, because the opioids are still in the system and will, after about 90 minutes, will actually put you back into an overdose if they don't get further treatment. If you thought someone was having an overdose and you made a mistake, you will not harm them in any way. So what happened, Kevin showed the picture of the opioid receptors. So Narcan comes in and knocks the opioids off the receptors, and the Narcan fits right in there. So just to review quickly, and we're doing this because for those of you who want kits to take with you, if you or someone you know is using, we just want to make sure you understand the process of how to use it. So you check if the person is responsive, able to be roused. We don't recommend a sternal rub, just yell at them or tap them, shake them. We would recommend calling 911 right away before using the Narcan. The video says use the Narcan first, but we follow the Department of Health guidelines. Then you administer the naloxone. For those of you who want, you'll get 2 in each kit. Unfortunately, what we're hearing out and about is that people who are overdosing of fentanyl may need more than 2 doses. But if you call 911 and EMS gets there, they'll handle the rest. So you'll have 2 doses in your kit. Rescue breathing is not necessarily, if you've been trained in it, you can do it. If you haven't been trained in it, don't do it. Turn the person on their side to the recovery position, and you can administer the second dose after 2 to 5 minutes if the first dose isn't working. Stay with the individual till EMS arrives, follow guidelines for incident reporting. For those who take kits, we'll give you an incident report form. We'd like to hear about successful reversals. So this is what the kit looks like. Narcan spray. It's really kind of nifty. I have one here that's open that you can play with if you decide to take the kit. Normally, this is not something you can test out because you'll waste the dose if you do. And as Gail said, they're about $90 a kit. Remember, if you take the kit, carry it with you. You never know where you might encounter someone and you need to use it. We just wanted to talk very briefly. There are in New York State and lots of other states, but I'll just talk about New York State. There's Good Samaritan law, so you are protected if you're trying to save a life. And we also have the naloxone access law. So there are lots of places to access naloxone. We passed out a sheet about where you can find it. And there is a whole Good Samaritan law. The Department of Health has it on the website if you'd like to read through it. Some people get nervous about these are there is this sort of interesting app I downloaded. It's kind of nifty, and it goes through the whole process of how to use naloxone. It's a free mobile app. Department of Health has great pages of all this information, and in your kit you'll have a certificate of completion. You can put your name on it. We've signed it already, and anyway, you know where the rest of that. So people are passing out the kits. If you have any questions, you can contact us, and thank you very much.
Thank you, Tracy and Kevin. All right, so we're coming around the far turn now. We have one more presentation, and then we're going to transition directly into the panel of Q&A. So I would like to ask Barry Lesson. Barry is with the Families for Sensible Drug Policy. CAADC is a harm reduction entity and public health advocate. Barry definitely fosters that. Barry will tell you a little bit more about what he does as he does his presentation. Barry, why don't you come on up and let's move this forward.
Everybody have the kits? We were here a couple of years ago for a panel with some of our friends from Harm Reduction Coalition and Local and the Center for Optimal Living. And it was, what's exciting is that a couple of years ago we were talking about the problems of opioid overdose and there weren't a lot of solutions. And there's been very discouraged in the political climate where there's a lot of pushback on trying to get our policies and work forward. But tonight is for our families who are looking for a solution, that being able to get these harm reduction solutions and strategies and tools in the hands of families before problems develop. So it's an honor to be a part of this panel, and I saw that when we were scheduling this last panel, but it's relevant in some ways the way that we look at families in terms of families are often disregarded or even abandoned by the treatment industry or the treatment program. I got involved in drug policy reform when I was 19, where the drug policy is directly that I was a part of, that these outlaws, ineffective, even dangerous treatment. Our families have been devastated as collateral damage of these methods, putting our resources, our hearts, our energies to an addiction treatment industry that has not only failed us, but traumatized us by imposing on us patriarchal, confrontational, restrictive, one-size-fits-all methods. Harm reduction is at the core of many public health problems that we know and we'll talk about tonight. And it does that by placing the self-empowerment of people at the center. The empowerment of people who use substances is lacking in traditional treatment. It's not only lacking, but it actually reinforces shame and stigma by blaming patients when treatment fails, and blaming our families by labeling us as the neighborhood codependents. Current prohibition-based policies intricately link the criminal justice system, including treatment into the criminal justice system. So the net outcome is really like it's often punishing people by simply acknowledging the progression of the disease, of the condition, and the steady treatment of people into the criminal justice pipeline that need treatment, or if they don't need treatment, they're still funneled into that pipeline. And these people are our sons and daughters, our mothers and fathers, our aunts and uncles, our grandparents. These policies and the government response of myopically reducing the supply of drugs without allocating the resources to reduce the demand for drugs and create dangerous markets and supply the demand that tragically that's what's happening. The policies also directly contribute to a cultural narrative that views substance use as the problem, ignoring the uniqueness of each family, the culture that it exists in, as well as the family strengths and individual resources. And this would willingly lose a family substance use farther down the continuum from safe use to more harmful use, and it also can damage family relationships that far outlast the substance use. You don't have to reinvent the wheel. Harm reduction, as we talked about here tonight, the harm reduction approaches are already in place in many other conditions. And simply put, we talk to our families about what they need to know about harm reduction is that it's love. We instinctively love our kids. We see that. Band-Aids on rather than following the advice of traditional support programs, use tough love and let us say bottom, which are both byproducts of prohibition and drug war. We need to trust our natural instincts and to love our children. Getting life-saving harm reduction strategies like these and tools into the hands of families, like I said before the problem develops, will prevent many of the overdoses. We do this in every other condition, and we must advocate for the same for substance. Our families are in a unique position to directly influence the direction and the course and the resolution of substance. And we deserve to have these options readily available to us in our communities. Our families deserve nothing less than the best care that we have to offer. Families for Sensible Drug Policy embraces the vision of support for families described tonight, and we are demanding that we include best practices as a baseline of every other condition. Our vision of support for families includes services that are integrated into a comprehensive public health from drug policies that will support and not punish, to early medical interventions, including primary care offices and emergency room staff, to reality-based education in our schools and communities for parents and educators. Family-centered support must be a priority. Family therapy should be a part of treatment where appropriate and fully integrated into the person's treatment plan to offer a healing process to empower parents and loved ones by providing a roadmap to help them be more effective family members. Effective family support will acknowledge that a young person's substance use is not the process, it's not a disease process, it's not the result of a disease process, but it occurs as part of a young person's normal development. And we need to focus on helping them develop the resources and the strategies and the skills to help them make better choices and to manage their emotions more effectively. We need to offer academic, peer, and community supports that are relevant to each kid's needs. Family support will be non-judgmental and collaborative and self-empowering, tapping into our resources and our resilience to help us become more confident about making the necessary changes to improve our lives. We'll include naloxone access and training for all providers who work with opiate users and for any family who wants it. And props to local people who this week passed a bill that will allow, and Robert talked about it, that's huge. That's something that like I said, 2 years ago, this was not talked about at all, but to have it in the low threshold population, where it's going to have effect. We are making progress. We are moving forward. We'll include supervised injection facilities in every community that needs one and wants one. And tonight is a beautiful example of the support, passion, and the solidarity of our collective communities coming together to promote sensible drug policies and the absolute best care that our families deserve. And we're not going to stop until this vision becomes reality.
Thank you, Barry Lesson. Thank you all of our featured presenters. I'd like to once again introduce Jennifer Talley. We're going to move right into the panel Q&A portion of the program. So we're going to invite up the featured speakers to the table, I believe, where we're going to then invite the audience to ask any questions that you would like of the panel. If the speakers can come up, please.
also wanted to mention that when we wrap up, we'll wrap up about 8:30, we'll also put materials up here in the front. So we have brochures and information that if you want to come by and grab it on your way out, that'd be great. We'll leave it up here for you. Okay. So if you are going to take that naloxone kit with you, please do fill out the form and you can hand it over to Lindsay. Oh.
I just wanted to make a statement, maybe an invitation. When I was watching that video, I have to say that I found it very upsetting. And it made me think about people that I've known that have died from overdose. And brought up a lot of difficult feelings. I found it hard to sit in my chair. And I began to wonder, how many people in this room have experienced similar things might also have had feelings and memories. And I think we're probably remiss in not having talked about the possibility that this could be very triggering for many of us here. And I want to apologize for that. But also to invite people to share if you have testimonials or just feelings or things that you'd like to share with the group to process a little bit or invite us to speak to. I'd like to invite them. And this is clearly not an academic, professional application for everybody who's doing this work. It's work that somebody said has to do with love and passion based on personal experiences or experiences with family, with friends, with loved ones. So just want to give permission to people who might want to speak about your own feelings and experiences to share with us.
So if you want to just raise your hand, then T. Thaddeus and I can come over to you.
Hi, my name is Jordan Leahy. My brother has suffered from this, and on the flip side, I have a healthcare software development company. So it's a complete different size of it. So he fits the demographic, 35, white male, working. He had some, I would say, emotional points in his life that really triggered that. So of the deaths in New York City and of those individuals who are suffering, do you guys have statistics on the types of insurance that they carry? And to follow up, whether it's Medicaid, private, and to follow up, there's also a blocker with access to care, oftentimes because of cost and understanding of how to afford. So any type of data or online resource that allows for more information about how much treatment really costs. This was the biggest blocker with my parents, just $30,000 for private pay. They don't have that. How do they pay for it? And now he's not in a good place.
So we don't have, unfortunately, the statistics for when we look at the mortality data, it doesn't have anything about insurance. So we do not know that. But I mean, what Sharon was talking about for treatment, I mean, I don't know those cases in opioid use disorder. But the first line treatment would be buprenorphine or methadone. So that is different from the cost of a $30,000 inpatient stay.
Exactly. But you mentioned that very few physicians, and I was actually at the Boston Opioid Hackathon last year. The biggest challenge that you guys recognize is very few physicians are willing to accept, because when somebody does introduce that, it's their problem. And there's like the accreditation competition or the of a lot of mandates.
Right, so while it is, it's been a challenge to get enough physicians and non-nurse practitioners simply to prescribe believe it is in New York City. We could help find somebody that would treat for sure.
Yeah.
Yeah, and that's not, yeah, Boston also.
Yeah, and I would just give a little plug to NYC Well, which is the city's, like, I don't know if they used to call that, it's the city's helpline, and they can actually talk through what kind of needs and someone might have and advise you on places you can get treatment, and they have sort of like a full spectrum of options, including providers you can offer.
And I've got to say, there's a lot of providers and people that are out there, unfortunately, that take cash only, but it's a lot less cash than $30,000. Some great providers out there, that's what they charge about. Is it outpatient?
And most insurance now pays for minority with small copay.
Last one, the payer, so this is also interesting. One of our clients called Sober, it's a peer-to-peer social network, like 100,000 individuals. They're trying to work with rehab facilities to provide like this peer support community. But the biggest block that they have is these rehab facilities. They don't want to adopt this because they don't want to actually, the market still is fee for service. It's not value-based care. So I was wondering, the payers play such a large voice in healthcare today. What is your guys' take on what they're saying to you, how they're trying to move the
Well, New York City is not a payer, and with Medicaid redesign, it's now it's private companies that are handling that area. I think that the whole payment system is shifting, particularly because of the way that Medicaid is working. So Medicaid sort of like sets some kind of a standard, and that then changes the way people pay generally. And so because there's so many changes in the system, and a lot of those changes that were made for Medicaid are pushing people towards reimbursements. There's peer reimbursements that now are actually pretty good reimbursement for peer services. There's good reimbursement, better reimbursement for reworking. There's all sorts of ways of providing services that didn't exist before. So with all of those changes that are happening, I think it's going to have an impact on other parts of the system. Yeah.
Yes, thank you.
Hi, my name is Juliana. I'm a former opiate and heroin user, formerly incarcerated, overdose survivor, and I've been on methadone and Suboxone. So this is regarding opiate maintenance. I'm not going to deny any of the life-saving benefits of opiate maintenance, but my issue with them is the lack of information about what it's like to actually get off of these medications. When I got on Suboxone in 2006, I was told there was no withdrawal. What I found out was it was the most hellish, horrible, long withdrawal out of all of the opiates, and I've been on all of them. It's the worst one. The only reason I was able to get off of it is because I went to jail and I had to cold turkey detox off of it in jail. I experienced withdrawal for the next year off of it. I think that there's a serious lack of disclosure of information about what it's like when you want to get off of these medications, and there is no procedure in place to help people get off of these medications. I feel like there really needs to be more of a focus on that, and more of disclosure of what it's like to get off of methadone and Suboxone, because people are still, I've worked in Ibogaine treatment. Even 2 years ago, I was getting calls from people saying that they were told there was no withdrawal. And I think this is a huge problem, and doctors need to be fully educated about what it's like to actually get off, and there needs to be a better procedure in place to step people off of this when they are ready to get off of. Because in my experience, being on Suboxone, there was this strange anesthetizing effect where I just didn't feel fully like myself, and I'm not saying that this is extremely life-saving and important to offer people, but I'm not so sure it should be the first line of defense, especially for adolescents. I think that there are other things that can be tried first before you get somebody onto something that's going to change their brain chemistry and potentially keep them locked into a medication for longer than they want to be on it. And so I really would like to see these issues explored more thoroughly. Thank you.
I'd like to acknowledge that we don't know everything there is about Suboxone right now. As I have Suboxone patients, and I have some that walk away and actually don't experience withdrawal. I have others that experience great difficulty changing from it, and I think that's been something we've learned not enough about, but we've learned about over the years. And there is no great way. I mean, I work with any of my patients that want to decrease and try to work one-on-one with them because we don't actually have the answers to it. That being said, I congratulate you on being able to be off right away with those medicines, but we do know that a lot of people relapse and die when they leave them. So I spend more of my time trying to reassure people that it's okay to be on them. You didn't feel right, you did the right thing, but I've also seen so many people leave methadone. I used to be medical director of the methadone program that went out and had a lot of really bad things happen. So I'm glad it worked for you. It doesn't work for everybody. And there is one.
Yes, a lot. I appreciate your sharing your experience. For me, it reflects, I work with families and young people in outpatient psychotherapy. I get families, the lack of education of other providers, of doctors, and we talk about the cultural narrative. I'll get calls from strangers who will say, what do you think about Suboxone? Is Suboxone okay? So Suboxone is okay for my kid. The family will come in. There's a sense that this is a pill that you can take that will, it's like a magic pill. So it's and there's a stigma attached to using the medicine. People feel like it's substituting another opiate, and just the lack of information as a provider makes it so much difficult to try to work with families. A lot of months before we talk, so we have to re-educate people about the lack of information. So your experience is unfortunately it's common. I appreciate you sharing difficulty with it, but it reflects the stigma that's prevalent in the narrative that makes it.
I want to make a harm reduction comment, harm reduction therapy comment. When I talked before about how I think that the data does not support a disease model, it supports a more expanded psychobiosocial model, an individualized model, really. I think part of the data is just reflecting on what we're hearing here, that there are many, many roads to recovery or to positive change. And that I think that one of the ways that I think about a harm reduction framework is that it's radically committed to not being ideological. That is not being like, this is the best treatment. My treatment is the best treatment. We need to stop imposing our values and our beliefs and our ideologies on individuals so that the harm reduction relationship is one in which we are there to support people in figuring out which path best suits them. Because some people find this to be, the wrong path, and some people find long-term maintenance to be really life-affirming and self-affirming. And we don't have the science to know which path is best for which person. So we need to come down on the side of, creating a space where we can support people in discovering that and kind of be on that journey with them.
Hi, my name is Lizzie. Thank you so much for your presentations. I've been working in the harm reduction drug policy space for a while now. I'm working in an academic setting now, and I'm curious. I've been going to a lot of these types of opioid panels, and I find that there's a very kind of stark distinction between what the main focus is. So on a lot of panels, it's all about prescribing, supply-side interventions, private intervention of opioid use in the first place, and that's really all that's discussed in the crisis. And then come to things like this that have a more harm reduction focus, and people are actually talking about heroin and fentanyl and things that we need to do to actually curb the overdose death crisis. And I'm just wondering how you think that we can start to stop talking kind of past each other, and how to spread the message that we kind of need to be focusing on this side and these types of interventions if we're actually going to curb the overdose death crisis, because just reducing the supply is a very kind of narrow approach to the issue.
reform conference just a couple of weeks ago. The harm reduction people hang out with the harm reduction people, and the dominant treatment model hang out with the dominant treatment model folks. So harm reduction people need to start submitting proposals for posters and panels and presentations at these mainstream dominant treatment model conferences and force that conversation among that audience. That, I don't take credit for that. That was Howard Joseph at the Reform Conference.
You're right. So so under my purview is actually the treatment providers that we fund, as well as our harm reduction and switch exchange programs, and we have actually been forcing marriages somewhat, and really trying to get people to start talking to each other and having conferences with both entities in the room and trying to talk about stigma and talk about breaking down those barriers and getting people to talk to each other. And I've actually heard from one government agency that they don't really believe we can use the HR words with treatment providers. In other words, the harm reduction words with treatment providers, and we do that all the time and really try and get that conversation going. So I mean, I will say I've actually been working in this realm only for a few years now, and I've seen a change just in a few years of people don't, look at you quite as funny as they might have before. So I feel like this is a time of some change, and that people who would never have talked about harm reduction or naloxone before are talking about it. So I think there is some movement there, but I totally agree with you that we need to really force that conversation more.
Hi, my name is Dr. Dara Hua. I'm a nephrologist and also a certified physician for compassionate care and cannabis use. And that's another tool that I found to be really effective in caring for my patients who want either to reduce as an adjunct opioid use. And the condition just recently passed this past March. But I certainly see people who are able to taper off their opioids, and legally I'm not supposed to give it to them as a primary first line of defense, but I see the damage obviously with the overuse crisis, and I will put myself forward as far as my own, I guess, liability and also the criminal defense of my practice. But when I discussed it, I certainly have sat in with at Cornell University when Commissioner Kunins was there talking about Suboxone, to a whole auditorium full of psychiatrists, and we talked about Suboxone, talking about methadone, and it really, I felt like fell on a little bit of deaf ears as far as the, so again, I'm not a psychiatrist, but I do use cannabis as a way as an adjunct, and I haven't seen that representation here as far as that as an alternative or a complementary or an adjunct when the health commissioner this past Monday has talked to providers about medical cannabis, and my opinion is again very poor showing as far as
Before responding, I just want everybody to know that we only have 3 minutes left to this program, and we have to end on time at 8:30. I'm going to redirect to the panel.
I think the data on cannabis is really growing, certainly as an adjunct. I think we need to learn more about it.
There was a data just out of Colorado.
Yeah.
So, yes, I mean, we're not doing anything with the city, but very supportive of the studies.
I want to focus on Suboxone and methadone. Overdose deaths are rising so rapidly. Really a crisis point.
We're at such a crisis point, we really need to make those things that are very well proven, not force them down under anybody's tongue, but make them really available for anybody that wants them, which we just heard from the gentleman is not so easy. So, but I think there's lots of other stuff we need to explore.
Sir.
Hello. Two-part question. I'm curious, if someone was born and raised in the South Bronx, what are some of the factors and variables that you found that contribute to this high increase of overdose in the region? I want to say it is considered one of the most unhealthiest and poorest congressional district in the U.S. or in the state. I mean, I don't want to say correlation and causation, but do you think that is a big factor. And the second part to the question is that I didn't see that much conversation on particular the ACE model, adverse childhood experience, and looking into trauma and how that has a very high, well, from what I read, it may be completely wrong, high percentage of those leading to substance abuse in the future in regards to that sort of ACE model.
So regarding the South Bronx, so there are a lot of factors, social determinants. But just to be clear, the issue in the South Bronx around overdose deaths has been like endemic. So it's not new. It's been going on for a really long time. The South Bronx, we take the South Bronx was a state. It would have the second highest rate of overdose deaths in the country. So there's like multiple factors, that exist and that help, shape that narrative, what's going on. What you're saying around trauma, it's not something that we're doing work at Beth Israel now, at the City Health Department, but I used to be at Beth Israel, I did research on that, and you're absolutely right, I'm sure there are others that could address that more directly.
I think we're just about out of time, so I want to say that we've talked about doing a part 2 of this because there's a lot of discussion that we didn't get to and a lot of presentations that we couldn't include today. So I think that those issues that you're raising are something that we may want to revisit with more depth. Is there a last comment from our moderator or Jen?
Just to echo what Andrew said, I feel like we could be here for hours, and I'm sorry that we didn't get to every question, but if you want to email me, if you have questions that we didn't get to, I'm happy to send it to the panel and then try to get back to you, so I'm happy to do that. And then you're on the list, people that signed up, so I'll send you an email to see if you want to join our mailing list, if you can learn about other events and activities that we have coming up. And please come by, we'll put our materials up here in a bit. And I just want to thank our panel for all the hard work and pulling this together with us. I really appreciate it. And thank you all for coming and participating tonight.
Yeah.